one. We have opened the webinar and we will watch for participants to join. And we have some attendees joining already. Hello, everybody. We're going to give everybody a minute here to populate and join the webinar. And I'm going to just do a quick slide share. And here we go. I'm going to keep an eye. Okay, good. We've got some lovely people joining us. So welcome to this edition of the Bighearted Warrior Tour, special edition with our partner Viz AI. Today, we're going to talk a little bit differently than most of our webinars. We're going to talk about technology platform using AI technology for ECG reads and how to implement that into an HCMA recognized center or your HCM program as it develops. So we have some amazing speakers with us today. We have Milind Desai and Matt Martinez and Jorge Silva. Jorge, I always mispronounce your last name. Could you pronounce it? Enciso.
Yes, Enciso, yeah.
Enciso. I have got to kick up my Spanish skills, and I don't like to mispronounce people's names. So as you can see on here, we have some disclaimers to produce from them as they're going to present on technology and the use of AI-read ECGs in their practices. I want to just take a quick moment to thank our staff who helps put these events together. And it's definitely a village here. And as you can see, we have a great team here at the HCMA, and they all play their roles in participating in different events. And Stacy Titus Brown and Julie Russo are backstage taking care of any tech issues that you may have issues with. Please use the chat feature to discuss with them. And on a housekeeping note, there's a Q&A area that you are welcome to add questions in for our panelists at any time. Just want to thank our speakers for participating today. And I am going to hand off the speaking engagement in a moment after I kind of set us up on what we're trying to accomplish here today. So we know the diagnostic challenge for those with hypertrophic cardiomyopathy can last decades. And we know technology is here to hopefully help us stop the time gap in diagnosis and be more accurate in our definitive diagnosis of whether somebody has HCM, amyloid, hypertension, whatever is causing their heart to be thick. So one technology that looks quite promising today is AI-read ECGs to identify those with HCM and flag the physicians within that healthcare system to be able to take action in a timely manner. There are a lot of workflow issues that need to be discussed about how to implement such a program into your program. And our speakers today have experience in that, and they're going to bring you some cases. The one thing that we as a community must do is build trust and establish trust ourselves in these technology platforms to ensure that we trust the data in every way. Whether you're from the patient lens, can the patient trust this? The clinician, can you trust this? We need to build trust in artificial intelligence and figure out how to make it work for us and make our life easier and not add complexity. But you're always going to get workflow changes up front that everybody's going to have to get accustomed to. So I've asked Dana Collins from Viz AI to come explain to us a little bit about the platform that they're offering and a little bit about the company and what trust they've already established in the neuro field. Dana, I hand it off to you, and thank you so much for joining us today.
Thank you, Lisa. Thank you so much for inviting me to be here with you all today. I'm really excited to discuss how Viz is transforming healthcare by closing the critical gaps between patients, clinicians, and life-saving treatments. What sets Viz apart isn't just the advanced AI, it's the meaningful difference we're making in patient care. Viz is reshaping healthcare by reducing friction, saving crucial time, and ultimately leading to faster, more effective treatments. So Viz is the most utilized AI platform in healthcare, with our journey beginning in 2018 when we received our first FDA approval. Since then, we've scaled rapidly and are now implemented in over 1,700 hospitals globally. Our reach extends through partnerships with the majority of the 50 largest IDNs and 7 of the top 30 life science companies. Truly a testament to the trust and impact that we bring to the field of healthcare. With 13 FDA cleared algorithms, this isn't new to healthcare innovation. We're well established in the neurospace with our platform demonstrating proven clinical outcomes and supported by over 100 publications. So building on this strong, solid foundation, we've recently expanded into cardiac care, specifically addressing a critical gap in the early diagnosis and treatment of hypertrophic cardiomyopathy. Our goal is to meet this significant unmet need with the same level of rigor and innovation that has made us a leader in neurocare. So one of our standout tools is Viz HCM, which is helping address HCM earlier and more effectively. So by automatically detecting early signs of HCM on routine ECGs, Viz HCM enables clinicians to begin monitoring and treatment sooner. So this shift to early intervention has a profound impact on patient management and overall quality of life. So by accelerating diagnoses, Viz HCM empowers these clinicians to intervene earlier and helps patients live healthier lives. So from an operational perspective, Viz HCM streamlines clinical workflows. Our platform lets clinicians prioritize cases based on key criteria. We can pull in various insights from the EMR and even access echo reports with real-time measurements. So this makes case reviews much faster and communication across care teams smoother. Plus, with customizable notifications, each care team member can stay updated in a way that works best for the individual. And of course, this all ties back to the outcomes. Viz's tools deliver measurable results, reduce treatment times, and faster diagnoses, because in healthcare, time is life. These real-world improvements lead to enhanced quality of life for patients and underscore the benefits of Viz AI, not just for healthcare providers, but for the lives of the patients that they serve. Then I'll hand it back to you, Lisa.
So you said you were going to do like 3.5 minutes, and I think you did that, but I think you provided some really interesting insight. And I did want to ask you about one of the collaborations that you're working with as well, and that's Us2 AI. So the echo elements of AI assisted evaluation of reports. Where is the Us2 AI in process at this point? Is that implemented into your system, or is that an add-on for the future?
So it is an add-on that we are able to integrate within the systems, and Us2 AI is a separate partnership that Viz has. So it would just be a separate add-on. But yeah, we can do that. We can pull in various measurements. You are able to flag different diagnoses like amyloid, heart failure, things of that nature through the Us2 technology.
Okay, great. Thank you very much for that overview.
Dana, that's the report, right? Not on the images, correct?
Correct. Yeah.
Thanks for that clarification, Matt.
Yeah.
So what we're going to do now is we're going to go into some cases. Milind Desai of Cleveland Clinic is going to do our first case, and then we're going to have a discussion over how we use the technology and where we might go from here. Milind, the stage is yours.
Can you see my slides?
Not quite yet.
Yes.
It says it started to
Kind of
share your
loading.
screens, but
Yeah.
there you are.
Okay.
You are live.
Thank you. Good morning, good afternoon to folks. Thank you for joining, and thanks to the HCMA for the invitation. So as along with the discussion, I'll highlight a case. We started collaborating with Viz AI, where all our ECGs are screened for HCM, at least in Northeast Ohio, and we plan to expand it through all our hospitals worldwide eventually. But at this point, I wanted to highlight one of the cases that we saw. This was a 64-year-old patient. ECG was ordered as a standard prior to pre-op evaluation before prostatectomy. Patient had a history of prostate cancer. This was ordered in a non-cardiology like pre-op clinic. History of LVH, or at least that what he was told, hyperlipidemia, hypertension. This is like, I would say, half the adult population in this country, especially with hypertension, hyperlipidemia, etc. No other real family history other than CAD and permanent pacemaker, certainly no history of HCM that was documented. Noticeably not on any cardiac medication. So this patient was earlier in our process, and the ECG was uploaded to the Viz server, and we heard back that it was flagged by the algorithm as suspected HCM. And we'll talk about the processes that we have put in place in a little bit, but this was brought to our attention, and the HCM team reviewed the ECG. We outreached to the urologist with our concerns. We did not obviously do the testing, etc. This is not our patient. And obviously, as a surgical team, they requested cardiac clearance. Patient was seen in the HCM center, and the bottom panel has the images from cine as well as Doppler images from echo, which confirm presence of normal ejection fraction, apical variant HCM, no SAM at rest. Patient also underwent exercise stress testing. Patient's exercise capacity was preserved, no evidence of ischemia. We made a new diagnosis of apical variant non-obstructive HCM. At the time, the imminent question was, we cleared the patient for prostate surgery and asked the patient to follow up in 3 months for additional HCM workup, including MRI, Xiopad, genetic testing, etc. And at the time point, when the patient eventually returns, we will be discussing various clinical trial options for non-obstructive HCM. So in addition to family screening, et cetera. So from a person who was meandering in the system with no diagnosis, now we have a new diagnosis and a potential for long-ranging plan. So before I end, and we will be discussing, I want to talk about artificial intelligence, cardiovascular imaging, making diagnosis, and I want to end by showing this story of this world's longest cow. Okay, this is the world's longest cow, and I want to highlight and caution, AI is as important as the context. Garbage in will be garbage out. So it is important in AI, training and validation data sets need to be representative of the gender and ethnic diversity. We cannot have an AI model that is based on 95% Caucasian, of which 80% are men. Having said that, we do have a very bright future for AI. I'll stop here and we can have more discussion. Lisa.
Thank you, Milind. I've not yet seen the world's longest cow.
There you go. See, I had to surprise you with something.
Yeah, you had to make me smile with something, the world's longest cow. So, Matt, you've been using this technology in your clinic. The case that Milind has presented, does this ring true with you? Are you seeing similar types of patients come to your attention that would maybe otherwise not have?
Yeah, I think it really highlights the benefit of this. There are folks hanging out throughout each of our systems that are unrecognized, and it's as you know, it can take years. There's published data on this, 4 to 5 years, multiple cardiologists. And what I usually say is, when I go on vacation, someone looks at my ECGs and says, this is a case that looks like apical HCM with those T-wave inversions. I saw one yesterday in the emergency room, went in for a pre-op for a hernia repair. They called a STEMI, deep T-wave inversions. The guy says, look, I just ran. I feel great. What are you talking about? So I was able to go over, tragedy averted, and he's going to be followed up and all as well. So what I like about AI is that it sits in the background as our supervisor and watching for these ECGs. It doesn't get tired. It does them late at night. It manages them on the weekend, and it's waiting to find those those needles in the haystack and then can alert you. Then you can spend a little bit of time usually sorting through it fairly quickly on your computer and saying, definitely this is concerning. They already have an echo. The echo suggests thickness. Now let's get an MRI and have them come see me. So it can be overwhelming to think about that volume. So far, that hasn't been overwhelming. There are ways to manage this. I think over time, you're probably going to have to create a better process for this internally. We are. I'm sure Milind is seeing the same because of the sheer size of their catchment area. But I think it's a huge opportunity. It's also an opportunity to engage the family medicine docs, the internal medicine docs, and the ERs, where it's very difficult to have them with such a broad practice scope, to have them only focus on looking at T-wave inversions and have them miss all the other stuff. So I think it's an opportunity for all them to improve the outcome. And then what I always think about is that, yep, it definitely helped the patient that Milind found. What about the rest of the family, right? We know that there's a 20-year-old or a 16-year-old in there that is living with HCM and is scary to think about the potential harm to the 16-year-old compared to the 40-something-year-old. So I think there's a huge benefit in that regard.
I keep going back to that pacemaker in the family history. Like, why was that pacemaker put in?
Yeah.
What's going on there? Is it an appropriate device? Is it not? Like, it could be perfectly fine, but I'd want to know more. Did you ever find out any more about that, Milind?
Yeah, when the patient returns for follow-up, yes. I mean, it's kind look, in real life, live medicine, the patient is, Biz flagged this patient particularly, and the patient is not really too keen on understanding the family implication till his cancer is resolved. So he's more interested in having that prostate dealt with. So, there's a time and place for everything. One comment I will make to piggyback, and I feel very strongly about this, is the AI algorithms are only as good as the training data sets that it has been validated on. And, all of us know, and Matt deals with athletes all the time. An African-American ECG may have, 20% STT wave changes, Matt, which you do not want each one of them to be picked up in a screening program as HCM. Can you imagine the furor or the fear that it is going to have? And so, like I mentioned a couple of weeks ago, I know the audience is a center of excellence audience. When I'm reviewing an AI paper, the first thing I look at is table 1. Table 1 is baseline demographics. I need to know what is in there and what is the representation. If somebody forgot to put the diversity part there, then they're hiding something until proven otherwise. So that is probably the most important thing I look at, or the lesson I want to learn from AI.
Fantastic. Jorge, any comments on that before you present your next case?
No, I think I agree. I think as the models are created based on what they're being tested from. And I think the models need to be diversified, as pointed out. I think you have to incorporate other ethnicities, other races, to understand what the global impact of other LV morphology is on those cases, to understand those ECGs. We tend to encase, everybody in the same bucket of the diagnosis when the manifestations can be so different. LV morphologies are very different than race and ethnicity. LV mass are very different, women versus men, for example, and also an Asian person will have a different LV mass compared to an African American person. So the diagnosis can be in a different stage in their life. So I think it's important to incorporate that. That if these are technologies being used, that hopefully the AI technology will be spread worldwide, and you can incorporate those models into our vast region. I mean, the U.S. is so widely diverse to begin with, right? Compared to maybe people in China, people in Latin America. So we have different, more select diversities, I guess. So it's important to incorporate those models into the AI technology.
So we'll go through your case, and then Dana, if there's any data that you have to go look at while we're looking at this data, about where was this algorithm, or how is the algorithm developed? Do we have good representation?
Yeah, so I can touch on that very high level briefly. So when we developed this algorithm, we utilized over 800,000 ECG exams from 300,000, a little over 300,000 individuals. And we looked at non-obstructive and obstructive, and we trained the algorithm using a diverse data set sourced from like multiple locations globally. So we really made sure that we had a diverse data set when training these algorithms, as we do with all of our algorithms.
Thank you. That was very helpful. Jorge, the stage is yours. Tell us what's
Great,
going
thank
on
you.
with your
Thank
program in
you.
San Diego.
Thanks so much. Thanks, Lisa, for the invitation to the ACMA, and thank you for all the attendees of today. So I'll just talk upon a brief case of an emergency, I guess, that happened on our system through the VIS AI alert. My name is Jorge Silva, and I'm the director of the ACM program at UCSD. This is the case. It's an 83-year-old woman from Ukraine, non-smoker, and she was seen in a different hospital system in our neighboring city. And she was being seen for potential coronary artery disease. She had a stress echo that was negative for ischemia. Baseline diagnosis, they were seen by a cardiologist, and the primary care was labeled as diastolic heart failure. Cardiomyopathy based on an ECG showing left atrial enlargement and LVH, also valvular heart disease with NMR and TR, pulmonary hypertension, as well as hypertension. And almost labeling and characteristics of people with heart failure will preserve ejection fraction. Medications were aspirin, apixaban, digoxin, metoprolol, succinate, losartan, Lasix, Crestor. She was really adamant about taking her blueberries on a daily basis, vitamin D, and omega-3s. She was hospitalized multiple times with atrial fibrillation and flutter within the period of 2023, by the end of 2023, and the beginning to the mid 2024, requiring just acute heart failure management with diuresis and also somewhat frequent cardioversions as well. She has a family history of just elder parents, a 92-year-old mother that was deceased, and her father was deceased at a young age during the war. And she has 4 children, one with disease from leukemia. So she was admitted to our hospital back in March with progressive shortness of breath and clearly just clinical manifestations of acute heart failure and atrial flutter. You can see on the right side of the screen the ECG, or just as typical AFib and flutter manifestations, as well as just some quite of a degree of LVH and some ST segment changes. After she breaks and she undergoes a cardioversion, you can just see some atrial bigymny, but you can see the profound STT changes there. These 2 ECGs that I'm highlighting are the ones that this AI alerted us, as Dr. Desai pointed out. You get an alert, you get notifications. We go into our medical record system and review who's the patient. At that time, the patient was being admitted, so we communicated with the inpatient care team about doing like photo diagnosis of this patient. And so that was the next step in her care. And so here's the surface echo that we obtained. Left side of the screen, you can see just quite large left biatrial enlargement, difficult to see endocardial borders here in this case, and unable to see while the apex echo contrast was used. And again, you can see just maybe a hint of the apical segments, just a bit hypertrophy. A lot of limitations in her case to see. So in this case, we decided and commented on the treatment team that obtained an MRI to further evaluation given the ECG findings. And so it was obtained as an inpatient, and you can see the degree of hypertrophy at the apex, even extending the apical hypertrophy to the mid-cavitary section, quite left atrial enlargement. Another view in the three-chamber view. Again, quite dramatic change to what we can see from echocardiography. So sometimes even the echoes can be not profoundly informative in some people, especially either they have lung disease or more advanced comorbidities. And so I think I highlight this case is that taking the further step, if you have a really abnormal ECG and the echo is not really suggestive, having further cardiac imaging I think is important because it's quite informative. The 2 dimensions that the echo provides sometimes not enough, that we need more data, more analytical studies in this case. So she was then diagnosed with apical hypertrophic cardiomyopathy. We've been seeing her in clinic. She broke from the atrial flutter, and she's doing okay at the time. And I saw her a couple of weeks ago, still having some issues with heart failure per se, given the size of the left atrium enlargement. So dealing with that. So one thing at advance I would say I don't have a large scale picture like Dr. Desai showed, but I do have a picture of the largest blueberry in her case. And so I would say not all the blueberries are the same. What I want to point out with this is that ECGs are good to screen. And once you find ECG that's giving you markers of hypertrophy, you can do proper screening, proper evaluation, find mimickers of potential hypertrophic cardiomyopathy, and also address the risk factors that many of these patients have, hypertension, diabetes, and so on. And with that, I'll finish my spiel. Thanks, Lisa.
Thank you very much. That's a really big blueberry.
Yeah.
I would love to meet this woman to find out what the nutritional and
I don't know.
medical
It's a
implications
tradition.
of
I don't know.
blueberries
It's
are.
something maybe Eastern European diet, I guess.
Hey, I love blueberries. I can do that one. That's an easy one.
Yeah.
Okay.
It's a superfood.
It's a superfood,
Yeah.
and that was a supersized
It is a good
superfood.
antioxidant for sure.
Yeah.
And maybe that's
So,
why she's doing so
Jorge,
well at
what I loved
83.
about the echo is that it does show a lack of taper, right? There should be a natural taper as you go towards the apex. And I think that we heard from James Moon and colleagues in the last year that really made me kind of be thoughtful more about how we make a diagnosis. For years, we've had the dogma, but we all know that clinically we make it differently than that. So if you have a lack of taper, that relative wall index that James Moon and colleagues have described, I think that case really highlights the benefit of looking at those in a different way. You can see how it just never got thinner. It seemed to get a little bit thicker as you went towards the apex.
Yep.
Hyperdynamic, really banging away.
Yeah.
Ejection fraction should prompt you, as you did, to go to MRI, which just it's like turning a light on in a room, right? Instead of using a flashlight, you flip the switch and you're able to navigate. And the MRI really illustrated that. I think we're going to get better in the next year or two about better describing this, in particular in women, which I think we way underdiagnose because of the size of their hearts.
One comment I'm going to add is, yes, it is important to consider MRI as the next step, but it is just as important, if not more, if you are suspecting HCM, if you have a funky looking ECG and your echo images, at least in our lab, it is generally a standing rule. If you are suspecting non-obstructive HCM, especially apical, you have to do two things: give contrast and make sure there's no apical foreshortening. It's always good to go to the next step, next test, but it is better to do the current test right.
I think that's a great point.
Yeah, I couldn't agree more.
Absolutely.
The other part is I think we under-recognize the association between atrial fib and I think that we go right to, well, she's 80 something years old, it's just atrial fib, right? Standard fare. I think we do the same thing in younger folks. I've seen a lot of lone atrial fib that when you go look a little deeper, you see extra meat there and you're missing the diagnosis. So I love that you showed a case where atrial fib was the presenting issue and then the thickness was sort of brought out as you dug into it. And again, AI nailed it, right? AI looked at those T waves and said, that's not normal. AI, the atrial fib is part of it, but the underlying substrate, as we heard years ago at that keynote from HRS, it's the substrate, stupid, right? Atrial fib is from something else.
Right. It's not necessarily just a symptom, it's a sign. And what is it a sign of? It could be a sign of many things. Let's find out why. We have so many patients diagnosed that way.
Yeah, to your point, Matt, is that this woman was seen multiple times in the ER and with other providers, and just being managed as a HFpEF with AFib. And I wonder how many in the community are like that, just trickling around with a carrying out underdiagnosis of HCM.
Yeah,
you bring up an excellent point, and this is probably the most powerful place I think this tool can be best utilized is in that ER situation or that preoperative screening. I think there's a lot that can be gained. Why are these frequent visitors to the ER? What is not being identified? Get that baseline EKG. We know younger people, they look good and they might have just mild abnormalities on that ECG that might not trigger somebody to think HCM, but the AI can support that decision and get them into the right diagnostic process. Milind, did you have another comment?
Yes, comment about the ER situation. I mean, look, ER is kind of like the Wild West situation. So we want to, yes, it would be a good ancillary tool, but it cannot take the place of human intervention, especially in a place like a high throughput place like ER. So I just want to make sure we don't get, every ECG, let's let it run by a ringer, by an AI ringer, and only the ones that are flagged for something that the ER doctor is going to go see. We cannot endorse that type of evolution. So, not that we are endorsing that, but I just wanted to throw it out there, make sure that point is made.
So obviously, I'm aware of another case that was in a hospital that was not anybody that's represented here today, but the ER triggered the alert, and the alert went to an individual, and that individual went, "Oh yes, this looks like HCM," and they moved very quickly to provide, therapy to protect against sudden death, but the full evaluation hadn't been done yet. So the trigger from ER is the trigger to you guys to say, "Hey, let's take a deeper look here, see what this is." But I do encourage, prudence and slow the roll, and let's figure out what's going on here before we start therapizing.
Yeah,
And
I think thank goodness for that, right? I mean, you're still going to need a brain on the other side to think through this. And, AI is a tool in the toolbox, but all that is thick is not hypertrophic cardiomyopathy. Certainly, we've all been burned on amyloid in the same way, right? Where it's atrial fib, and I look at the ECG and say, well, it must be HCM, and then you look and you're like, well, it's kind of low voltage. Maybe this is amyloid. And so you still need to be thoughtful about this, and that's one of the potential risks, as Milind points out, spot on, that it's not an answer, it's a tool. It's going to spit out a probability. And VisAI has been very clear about that. It doesn't say it's this, go do this. It says probability of, likelihood of, which then thankfully allows a doctor to make some decisions about this, because an 83-year-old with HCM is very different than a 16-year-old with HCM. There's really no urgency to go drop an ICD in somebody who hasn't been fully assessed.
I have a question. Since we are having this conversation, Matt, and I'm gonna put you on the spotlight. So the business of expanding the pie, obviously towards the younger population, children, high school, etc. Back in the day, some well-regarded professors have insinuated that in a country as diverse as the United States of America, these kind of programs do not work. Do you think we need to revisit that notion in the face of currently emerging evidence? I'm choosing my words carefully.
Yeah. So I think the short answer is we need more data. And you started with what goes in must be sorted out. You've got to figure out what went in. So I use my own family example. So if I came home and said to my dad, good news, I have an abnormal ECG, all I have to do is see a cardiologist and I can play football. He would have said, well, I guess we're not playing football. Because that's the potential harm, that we can be excluding children, which has still been the argument of that well-thoughtful professor who you're alluding to. And I still think that's the case. We need some more data. We need some more information. But yes, I love the idea of being able to screen a city of 3 million people like Cleveland and be able to identify people. However, the next step of this, and you're a step ahead of me as usual, is there's got to be a process. The challenge with ECG screening is, what do you do with them when you find them? So we can't just send them home and say, good luck, hopefully you find somebody to sort this out. It's what's the next step. So when I tell people about ECG screening, I tell them, first things first, what's your process to handle the abnormals? What are you going to do when you find them? Because if you don't have a process to get them out of trouble, you're going to disqualify, you're going to cause more harm than good, which has really been the argument that all of us have spoken about for years about generally ECG screening. I hope someday we have the ability to do this more completely, where you can screen masses of people. And so we're talking about inner city Newark and places like that potentially have some access. But what about rural Montana? What if you're in the middle of Montana and you've got to drive 6 hours to get your MRI that says you're fine? No one's going to do that. Telehealth, I think, will help this. I think that will really move things along. But I think we're getting ahead of ourselves. I think we need more data. We need more evaluations. But I love the way you're thinking. I think there's an opportunity to really do massive review, as long as we've got a process to handle those.
Another point I I want to make you alluded to, it's not just about the athletes and what the heck are we going to do with the massive influx of people with possible. It's even right now, as the process is being employed through the systems, what do you do on a daily basis when you have a data dump that says you got mail, like the old times, you got 1,000 people with potential HCM. So right now, to Lisa's point, till we build the trust, we are doing manual review of all these cases.
Yeah.
Trust but verify. That's what an old president said once. So, we are building that. But for this to be sustainable and viable from a business standpoint for an enterprise, for an organization, some version of AI in electronic health records has to be employed, where when Dana sends me a list of 1,000 patients, the EHR somehow does its own set of AI and say, Milind, by Desai, out of the 1,000 that were sent by Dana, you and your team need to be focusing only on 100 of these. You see where I'm going? What are your Jorge, what do you think? And Matt, what do you think?
Yeah, I completely agree. I think you don't want to overburden overload the system we already have in place. As you know, I think many of this talk have probably used Epic, and the Epic best practices advisories and alerts, and it's also the inbox is just flooded every single day. I personally, just can keep up with all the inbox that I get all the time. So having in place the AI system where it can facilitate the physician to just, okay, so have a label, I'll review these ECGs quickly, and then I can move on to the next case of testing and diagnosis is important. I don't have time to review 1,000 ECGs that are potentially labeled as HCM. It doesn't operate with the workflow between your APPs and nurse navigators and having contact patients, contact providers, and so on. It will miss the point what AI wants to do, which is close the gap in terms of the lagging the diagnosis. You want to make sure that you do everything in a spit-fast fashion, that the AI is doing its job by recognizing the hallmarks of HCM, and then the next step in the testing to facilitate for the provider just to make it very quick. Great would be if if the AI integrates into the EMR and it finds already people that have maybe an echo already, they can look into the report, see what the profile looks on that. That would be helpful, but that is more to come. I think still needs a lot of manual labor in a way.
I think what we're talking about here is not only the AI trigger, but the response to that trigger and setting up best practice workflows to a Dear Doctor letter, to an engagement, and the patient has to get notified somehow, right? Like, okay, here's this information. We're not going to have some doctor that's not attached to their care jump in and say, hey, guess what, found out. So we have to get that pathway of communication and then that support to that patient. We know that this is a lot of information. We know we just said some scary words to you. Let us help you understand what all these mean. And that's where HCMA is trying to find where our space is to be involved with that communication with the patient as they go through that diagnostic journey with your teams, and making sure that they understand that this isn't just something to be ignored and that their families could be implicated here. So while we may find a lot of asymptomatic people, we may open Pandora's box on a lot of very complicated families with generational issues that are now coming into focus thanks to technology. Who wants to talk about workflow? Matt, can you tell us what you've done at Atlantic Health?
Yeah, I think for now, the answer to that workflow is it's still singular, where I still sort through it and have to review them myself. But as you think about scaling this, there's got to be, as Jorge said, some sort of a screening process on the back end by somebody else. We all went through this with loop recorders and with Apple Watches, right? Where you got an influx of, hey, doc, I had a rhythm change. Hey, doc, I had a rhythm change. And your answer is, that's still a PVC. That's still a PVC. So is that. Stop. As I said to my child once when they were little, you used up all of your questions for the day. Like, that's it. So that's the current workflow, is that most of it comes through me. I think you can envision a process where you could have a nurse practitioner, a PA that is working with you, an APP that could definitely start to screen through this and just determine that they need an echo or not. And then they kind of triage them. I think a really well-trained nurse can do it at a high volume center as well. But at least for now, it is definitely me who determines next steps.
So what have you done? Are you sending a dear doctor? How are you engaging on some of these positive hits?
Yeah. So most of the time, so we're limiting where the EKGs are being used. So where they're not as diverse as, like for instance, the emergency room doesn't have the technology overlay yet. And part of it is that the noise challenge. We do a lot of TAVRs. We've done well over 5,000 TAVRs. So you're going to pop a lot of aortic stenosis and a lot of TAVRs that have been done that still have extra thickness. You're going to find all kinds of noise. So for now, we've limited it to folks that are referred to me that are coming into the program, and to some selected cardiology groups that are more interested in being called and saying, this looks like HCM, can you refer them? Because there is a risk that you upset people by calling them, and if you do a direct to patient letter, you can really run the risk of hurting. The referring docs don't like that when they come in with a, hey, this says I have something. So at least for now, we've used it with a group that are a little more apt to refer.
Yeah.
So can I make a comment here? So we have taken a slightly different tack by design. So we have opened the floodgates to everything. First, I want to understand, like to Lisa's point, we got to understand a cadence and the trust factor with the technology. So we have like, I don't even know. I think in Northeast Ohio, we do 1 million ECGs or something like that a year. That some ungodly number. But we want to see what we are dealing with. And I chose just not to look at our patients, because our referral, if I just look at HCM clinic patients, it's like talking in an echo chamber, like we've heard in the last few months. So we don't want to do that. And where we have done in terms of the workflow is, once we get the list of people with probable, we are still doing it manually, where we have a nurse coordinator, Katie, and some of the other members of the team, including some research fellows. We are sorting it out, but I have an academic mindset behind why we are doing it in a more formalized manual way to understand this better. But this is where I was saying, for this to continue to be viable, we have to have a second AI stream in the electronic health record that will help us separate the ASs from the true HCMs.
So question, Milind, which population are you using the technology on? What is the entry point for the EKG to be put into the Viz AI system?
You are a patient of the Cleveland Clinic.
But not the emergency room.
It may be in process. We were just talking, we have not implemented it in the emergency room yet. But my goal, every patient that comes to, we started with the J building, so the heart center, then we expanded to main campus. Now we are going to the region, and et cetera, et cetera. So at this point of time, every patient, we could just restrict ourselves to cardiology. But I think, if you want to move the needle to improving the diagnostic yield of HCM and not miss the 85% undiagnosed that people talk about, then we have to, I think, I may be wrong in my belief, we have to expand it to where the patients are. You don't just, we've just come through an election. You don't just, go in your precinct. You have to go where the people are.
Yeah, I think you're spot on. I think some of this also reflects the amount of resources and the size, right? So if I did that, I would spend all of my day just reviewing ECGs and figuring out that. And we don't have the bandwidth for that, and nobody will pay me to do that. So I'll be an unemployed, really good Viz AI expert. So that would be bad. So I think that's number one. And then number two, you can adjust the probability. And Dana hasn't touched on this. You can adjust the probability to make it very specific and less sensitive. So you can adjust where you want to be, and you can actually tailor that based on where you're doing it. So in the emergency room, you may want high specificity, as opposed to an outpatient clinic where you may be more comfortable with doing a little low sensitivity. If it's a family doc and urgent cares and pre-ops and things, that's the group I'm trying to capture, because that's actually what we see a lot of, where they get flagged by an anesthesiologist who says, I'm not giving them propofol until this gets cleared. So that's a group that we're still trying to help capture.
Yeah.
Jorge, how
if
are
I
you
can share
using
my experience, because we participated in a pilot project. And so we expand not only to the outpatient clinics, but the ER. And we were getting a lot of noise in the ECGs for the ER specifically. And also what we found out is that many patients were lost to follow. They were like one time show up in the ER visit and that's it, you know. It's someone like they go to that barbershop and then they go to another barbershop. It's just that we could not find those patients. We just saw they were flagged, the ECGs, but there was no follow-up, no diagnosis. They weren't able to find those patients even for calls. So we have now transitioned just to the outpatient settings within all the UC Health. And that's helped a lot to communicate and close the loop with primary care providers and cardiologists that follow these patients, and has opened the conversation just with the next steps testing. I think it's great to do it in the ER. But as long as, you know, if these are patients, like they belong to the health system, like Dr. Desai mentions, that's helpful. But where we work in our centers, we have a lot of people that just walk in and walk out, unfortunately.
That's sad.
Lisa, another important thing is you said, you know, the Dear Doctor letter. There is, you know, it's also a learning curve, and I experienced multiple emotional states from multiple doctors who got this email, including, hey, thank you. Can you deal with this patient? Thank you for your, you know, can you help take care of this? Versus, who the heck are you to tell me how to manage my patient? Versus, thank you for the wonderful note, but this person has documented AS and we will stop here. So we have to, it's not a one size fits all that is going to be the case. And one of them, you know, who was, I mean, I'm not going to use the word nasty, but, you know, who was sort of, who got ticked off that they got an email like this. I had to have a personal conversation. Hey, this is a process we have implemented. And, you know, if you don't like it, tough noogies, you know, I don't like to, you know, this is a institution mandated process. So,
So let me ask you guys a little bit about the institutional aspect. So this webinar is intended for those who have programs similar to your own. How was it working with your institutions to onboard this technology where data that is being acquired at your facility is going to a cloud-based system? Was it a difficult process? What are the steps to get a program implemented? Who wants to start? Jorge, let's go with you.
I'll do it. So the way that we started out, I mean, again, it was very involved manually, getting the flag alerts of the ECG in review and contacting the providers for it, contacting along with the RAPPs and the nurse navigator that we have. And once we contact the provider and we have a positive feedback from the providers, then we schedule the patients to get the diagnostic testing. Because you know, full disclosure, the Viz AI has worked with us in the UC Health environment for the stroke algorithm. So we have a lot of support with that background, that relationship that we had in the past. So the cardiology division was open to implement that in an institution. And so that gave us a bit of a more gamut to just go wide and spread the conversation. We did find, though, as Dr. Desai pointed out, a lot of mixed bag of emotions, and some providers, the primary care providers, are super receptive to this technology and super receptive to say, you're taking the next step as a cardiologist, that, hey, your ECG looks abnormal, let me help you, and let me order an echo, and or I can see them in clinic and so on. I say, for sure, absolutely, no problem. Is when the cardiologist gets involved and you nudge on the cardiologist, they get a little more sensitive about this topic, because sometimes they feel, and I've gotten like this, like text message from my colleagues, like, did I miss something on the ECG? Did you tell me something that I didn't do? So they get a little more defensive about it. But the workflow is just as many have pointed out. When you review the ECG, you get the alert, you sit down with your team, you send out notifications within the Epic system and messaging, and then just go from there. Again, the other thing that we've done, and we typically have a monthly faculty meeting with the entire division. We also spread the word within the faculty division that we're going to implement this technology, so everybody's receptive and knows about getting notifications when this technology flags and sends them a message within the Epic system.
Matt, you have a different healthcare system on the East Coast. How did you implement the Viz.ai technology and, you know, the yucky contracting kind of stuff? And how do we actually do the connections?
So say that part again, the contracting
How do you
part?
actually how do you start the process? How do you get an account going? How do you get your institution comfortable and signed up?
Yep. So challenging in this environment for sure. We are very patient centered, so much so that I think it could potentially hinder our movement forward. It's taken a long time. Viz is very flexible. They've got great systems in place, and they've got a bunch of places like Cleveland and San Diego who are already on board. So that helped quite a bit. When our legal team starts to hear about other places that are doing it, this is not as kind of absurd as it can sound. That you're going to let somebody overlay onto your Epic and whatnot. So it takes a little bit of back and forth, but because it's not the first time, it is Viz is apt for this, and they went back and forth with redlining quite a bit. So that was the biggest hurdle, was the legal team for sure. And then we have a boilerplate kind of letter that we have written to the providers. And again, we've started with folks who are already actively sending me patients, that are very engaged. Our system is set up so that a lot of people pollinate Morristown Medical Center and Atlantic Health System, but not all of them are only using Atlantic Health System. So there are those that are part of my partner group of 1,000 docs and providers, and then there are some that are kind of on the periphery, as you know, Lisa. So we have to just tread a little lightly with that group, because you don't want to make it look like, as Jorge said, that I missed something. Who, are you telling me that I blew something? And there's some challenges with that dynamic for sure.
Interesting. Okay, so Milind, I'm assuming that Viz.ai already had a relationship with Cleveland Clinic on the neuro side, and you bring them into the cardio side. How has that process been for you?
Yes and no. So it got them an entry to the front door, but HVT, Heart Vascular Institute, is a slightly different entity, as you very well know, at the Cleveland Clinic. And the biggest thing was navigating the climate has changed, obviously. Organizations of our size, we are very protective of our data going out. So, it took us a fair bit of legal back and forth with our AI compliance committee, research compliance committee, our what you call strategy office, et cetera, to come to that agreement. I got the key stakeholders there, and there was a lot of back and forth ping-ponging going on. So obviously I had multiple back channel conversations to move things along. But do not underestimate that part. Then comes, where is the upload gonna happen? So our Muse ECG system. So I had to get the Muse police on board and create the nodes of direct transfer. And so first is the legal and compliance, then is the how we are gonna do it. Then what the heck are we gonna do when we have the data back to us? And so that process that I've already talked to you about, I have a team of people that sort through this, and then we have a letter and an email process. So far, every every notification that goes out electronically, I'm copied on it. So I get a barrage of these emails, and if there's a back and forth, then I have to deal with a few of those. But I think, the why is important. So selling it to the leadership that this is an important part, then the legality, then the how process, and then what the heck are you going to do downstream? I think those are the things. And every organization is going to be different in their challenges, but operationalizing this requires just breaking it into pieces. Otherwise, you'll be just circling around.
That was helpful. Okay, so I said we might do a third case, but I think we really handled the operational aspect of the technology quite well in this last segment. We have another 5 minutes. If any of the attendees that are still online have any questions, this would be the time to ask them. But I'm going to go out on a little bit of a ledge here to say that for those of you who are in an HCM center and are interested in maybe talking to Viz AI about integrating their technology, I'm going to volunteer Jorge, Milind, and Matt to be available to you to ask questions of, because they're actually using it and they may be able to provide you with some best practices, which frankly, this is the type of segment that you're going to be seeing more from HCMA, all best practices in every element of an HCM program. So if you've got an idea that you want to see on a future event, please let us know. But for this one, I'm voluntolding some people that they can help you. But then going back to Dana from Viz AI, and she's been watching and listening. Dana, is there any aspect of onboarding or technology integration that interested parties should be aware of, or how do they start this process with you?
So I did want to touch on security because you had mentioned that, and I just wanted to call out that we have the highest level of certificate. We are SOC 2 Type 2 certified. When we implement with a respective health system, we go through a security review and we execute non-disclosure agreements, and we provide our IT documentation, certified attestations, and then we look at data flow diagrams and gateways. It's a very in-depth, thorough process. And we do majority of the heavy lifting with help from the IT teams at the respective hospitals, but we prefer to carry that burden, the majority of the burden, the heavy lift. So I just wanted to call that piece out for security. As far as getting the process started or having a conversation about setting up HCM at your center, you can reach out to myself and I can drop my email in the chat and I can direct you to the appropriate people to have that conversation and get things underway.
They can also contact Stacy here at our office, and Stacy will make sure that those connections are made.
Yeah.
In the last 3 minutes, can we talk a little bit about cost? Is there a cost associated to onboarding Viz, and how are those costs handled?
Right. So right now, for Viz HCM, there is no cost. So we've been doing 2-year programs, like 2-year contracts with customers at no cost. And when we do the HR integration, there could be some additional costs, but oftentimes there are not. And it all depends on what the site's contract is with their EMR. So we'll do our due diligence and we'll go through the list of APIs that are included with the customer's contract and kind of guide on where we think we should turn that on. We don't really want the customer to have to incur any additional costs for this program.
And I think that's a wise idea. And I think it's an important conversation to have, because we talk about technology and then everybody's like, I don't want to even ask because the prices are going to be too much. There's no downstream here. Okay, so Dana has dropped her information in the chat for those who might want to pick it up from there. again, if anybody wants to talk to Viz directly about integration, please get in touch with them directly. Or if you want to follow up later, you're not watching this live time, you can call the office and we'll connect you. We'll go Milind, last thoughts, Matt, and then Jorge. You each get 30 seconds.
So I will remain with what I started. It is important that a company like Wiz continuous improvement is better than initial excellence or what have you. So their algorithms need to be continuously iterated with new information so that the accuracy remains at the top-notch level. You cannot be caught up in the hype and forget the basics. Tom Brady was Tom Brady because he woke up every morning and practiced the heck out of his craft.
And we do that, to add to that, Dr. Desai. So for all of our algorithms, they're constantly being updated as we're ingesting data.
It's a permanent improvement process that into
Correct.
the infrastructure that is the AI.
Yeah, that's correct.
Perfect. Matt, you're
Yeah,
up next.
I think we have to move beyond where AI is coming to the reality that AI is here, and it's already being used in a lot of our hospital systems, and has been for years. Even if we don't know that, it is absolutely still coming. So I think this is the beginning. I think that it's great if we can get more people on board. It's just going to feed the amount of information we understand, and then learn, as Lisa says, best practices that we can figure out where those challenges are, figure out if we need more resources and how to best utilize them. Because as we all know, if you just go to the hospital and ask for resources, you're going to give me a business plan. Where did all this come from? So this is our ability to build that infrastructure, and then we can share it. All of us can share what we've used for successes. And then, as Jorge said, where are the landmines? If, when we started in the ER, there was tons of noise. This was a disaster. Don't start there. Or whatever the case is. And I think we're all going to benefit from this. It's an opportunity to improve the patient care and to find more patients. We have better therapies than ever before. This is absolutely what you need to use going forward.
Thank you, Matt. And last words to Jorge.
Yeah, I can't read it. I mean, everybody has said enough and check on all the checkpoints. I would say that this is a blessed opportunity to use this technology for those that are not really well-versed or educated in cardiomyopathies in general. So the primary care physicians being like on the front runners of and the leaders of caring for these patients, which are the referral basis, to educate that workforce, as well as some of the nurse practitioners and APPs that see these patients on a day-to-day basis. I think it's important to just open up this conversation and use this tool as a next step in technology and diagnosis of these patients. I think this is going to be great. But definitely have a very close loop, open conversation. And just as Matt pointed out, just be open to the idea that this is just part of our infrastructure now.
That's a good closing comment. I thank you all for sharing your experience with the platform and the technology. Viz AI, thanks for creating the platform and technology. I think this is going to be a critical tool in the diagnosis of the undiagnosed right now. And we have a lot of people out there to go find. And it's going to be slow until we figure out how to do this at mass capacity. But right now we're learning, we're growing, and we encourage all of our centers to at least have a call with Viz AI, learn what it can do for your system, what needs to be done to implement it. A conversation's a conversation. If you implement, great. If not, I'd like to know why. But I think there's an opportunity here for finding the undiagnosed that we never had before. So I thank you all for sharing your time and talent with us today. And for those of you who are viewing this after the original program has aired, if you have any questions and you need to follow up, please do not hesitate to email support@4hcm.org, and we will channel your question to the appropriate member of the team. So thank you all very much. And we are officially going to end the webinar. Have a great day, everybody.
Thank you.
Thank you. Bye.
Thanks, guys. Bye-bye.